Ready to write. I think we should go ahead and start the grand rounds. Good morning, everyone. So today I'm going to talk about late preterm infants, which are almost there, but not quite. And this is my disclosure. Unfortunately, I do not have any financial statements to disclose. And I do not intend to discuss any unapproved or investigative use of commercial product or device. So the objectives of my talk today are describe the magnitude of problems of babies born in late preterm gestation, potential explanation for recent trend of rise in these babies, and explain the risk of infant morbidity in the late preterm infant and common complications in this population. So why do we need to focus on the late preterm infants? These babies who are born in late preterm gestation, they account for about 2/3 of all the preterm infants we see in our neonatal ICU. They appear mature at birth. They are about 2 to 2.5 kilo. They are relatively stable in the delivery room and are usually taken to the newborn nursery. So these babies, they start well, but they have potential for complications. And in my review, all recent publications which I saw, they are talking about these babies and how they are at increased risk for problems because of delayed transition and immaturity. So we need to talk about these babies, and I'll try to let you guys about these babies and how do we manage these babies in our neonatal ICU. So how do we define these late preterm gestation babies? These are the babies who are born at gestation of 34.07 weeks to 36.67 weeks. They were used to be called as near term, but now the consensus is to call them late preterm infant. And there was a workshop which was done by National Institute of Child Health and Human Development in July of 2005, which suggested that this later terminology of late preterm infant conveys us sense of vulnerability. So every we count when we look at these babies, the more mature you are, the better the chances. So you can see the trend. This is from 1990 to 2006, but as you can see, from 1990 it was about 6.8%, and it has increased by about 20% to now. In 2006 it was 8.1, and currently it is at around 9%. So there's a steadily rise in these babies, and most of them are now mostly due to the 36 weeks gestation, which is increasing more than 35 and 34 weeks. If you to put in other words, if we compare the babies who were born in 2006 and 1990, so there will be 50,000 more infants who are born in late preterm gestation in 2006 as compared to 1990. Or on an average, there are 900 late preterm infants who are born every day in our country. If you look across the different age group of women who are delivering these babies, there's increased in the rate of these late preterm in all the age group, but it's mostly in the early age, which is less than 20, and those who are more than 40 years of age, they have significantly increased in numbers of late preterm birth. If you look at by the race of the mothers who are giving birth to these babies, for the non-Hispanic Black, the number pretty much remains the same, but the significant rise is in the late preterm births in non-Hispanic white mothers, and that number has increased from 5.5 to 7.4%. So there's a significant rise in last 20 years or so. Across the country, if we look at the late preterm birth, you can see mostly is blue, which is about an increase of 20 to 30%. And for Louisiana, it is better than the other parts of the country, which is about 10 to 20%. But as you can see, there's nothing which is decreased. So everywhere the rate is rising. Maybe DC is one small area. So why is this shift? Why these babies are being born early? And the reasons are not very clear, but we know that the labor and delivery, how it has been managed in 1990 and now has changed tremendously. There's an increased rate of induction and C-section for these babies due to various factors. And because the neonatal management has also changed over the years with the use of surfactant, more of these babies are doing better. And for that reason, the OBs may have an increased confidence in our ability to take care of late preterm infants. So they don't hesitate as they used to do in the past to deliver these babies at early gestation age. And there are also medical interventions which they are doing at or after 34 weeks of gestation for conditions like preeclampsia, multiple gestation, twins, triplets, or if there is a spontaneous preterm labor or prolonged rupture of membrane, and for the prevention of stillbirth. So this is again the same trend which we are seeing from 1990 to 2006. The rate of cesarean section and induction of labor is increasing for 34 to 36 weeks of gestation, and this may be one factor which is contributing to the increase in the late preterm babies. And this is a common scenario which we face in our neonatal ICU when we get the OB consult. The 38-year-old G3P2 mother with severe preeclampsia at about 34 weeks of gestation is admitted to the labor and delivery. She has difficult to manage hypertension, and because of that she has a poor fetal growth. So for that reason, the OB, they decide to deliver this baby because there's a risk for the maternal and fetal, for fetus both, and they want us to talk to this mother. So we need to know what are the complications related to these babies if they're delivered at 34 weeks. And in cases like these where this mom has very difficult to manage hypertension and the fetus is not growing inside, it might be an optimal gestation age to deliver this baby. So sometimes we cannot argue with the OBs because of these factors to delay the delivery. So sometimes these babies are delivered at 34 weeks of gestation. And again, in this slide, the same which I told you, if you wait, there is a potential maternal and fetal consequences of continued pregnancy. So in this case, which we talked about preeclampsia, the mom can have eclampsia, seizure, and other complications, or hemorrhage, hypertension, and uterine rupture. And also because of that, the fetus can be at risk and can have a stillbirth or further decrease in the growth because of the uteroplacental insufficiency. So it's very hard for the OB sometimes to decide what is the optimal timing for the delivery. Because if they wait, the mom and fetus can have problem. If they're born early, there's a potential for maternal and newborn consequences because of the late preterm and the early term birth. So we don't know what is the optimal timing for the delivery. Talking about preeclampsia, this is the most common complication of the pregnancy. The incidence is about 6 to 7% of all pregnancy, and the risk factors are chronic hypertension, obesity, multiple gestation, renal disease, and previous history of preeclampsia. Is preeclampsia a cause of increased late preterm birth? Probably yes, because these moms are very hard to manage. And I said when they reach to 34 weeks of gestation, the OBs have to decide should they deliver these babies or wait for maternal problems. Barton in 2001 did the study and found that there is a 15% increased risk of late preterm delivery in preeclampsia. There's a review article which I was reading from 2006 by Sibai, and the OBs do acknowledge that there is an increased risk of neonatal morbidity and maybe mortality in these babies, but they justify the early delivery in mother with preeclampsia due to increased risk of maternal and fetal complications if this gestation is continued beyond the 34 weeks. How about the preterm labor? We do not have good medications or good ways to stop the preterm labor. I mean, the tocolytics are usually ineffective, and some things like indomethacin, Maxalf, they can cause serious and fatal maternal complications. So the obvious thing is there any threshold beyond which there is no point in attempt to delay the delivery? And I think from my experience in the last 3-4 years, they usually, when the mom reaches 34 weeks of gestation, they start talking to us about delivering the baby. And here they do the fetal lung maturity, and if they can show the evidence of fetal lung maturity, they tend to deliver the babies. How about the prolonged rupture of membrane and chorioamnionitis? It does increases the risk of preterm labor, and there is no evidence to support any intervention to delay deliveries in these cases will improve the neonatal morbidity. The multiple gestation is also a major cause for increase in rise of late preterm birth. If you look at the singleton gestation, about 8% of these babies are born late preterm. But for multiples, 38% of these babies will deliver in the late preterm gestation. And if you look at overall, this is probably from a couple of years ago, the rate of these deliveries is about 9% of total deliveries in US. So in 2010, there were like 4 million babies are born in a year. So the 9% of it is approximately 350,000 late preterm infants are born every year in United States. Mean gestation age at birth for different plurality. For singleton, it is 38.8. I think this has also changed because of the induction and the C-section rate. Earlier, it used to be 40%, around 40 weeks of gestation, and these babies are now being delivered earlier and earlier. For twins, it is about 35 weeks. If you are triplet, the risk is about 32%, at around just the delivery is at 32 weeks, and for quadruplets, is about 30 weeks of gestation. But there's a decrease in the triplets and quadruplets because of the assisted reproduction has been refined. I think it's getting better and better. So we are seeing less of these triplets and the quadruplets. So, but we are still seeing the twins who are sometimes just natural. How do we manage the multiples? Is there any effective way to deliver these babies late? Probably not. When they have tried cerclage and tocolytics, which are ineffective. There are trials going on for the use of 17-hydroxyprogesterone and omega-3 supplements, but so far the results are inconclusive. And because of this multiple gestation, there is a uteroplacental insufficiency which can cause the intrauterine fetal death or demise. So current recommendation from the ACOG is to deliver the monochorionic twins at 34 to 35 weeks of gestation after the steroid is administered, and sometimes they will do the fetal lung maturity testing. So what are the complications of late preterm infants? As I said earlier, these babies are born somewhere around 2.5 kilo, or they may be between 1.5 to 2.5 kilo. And we call them, I mean, it's not a commonly used terminology, but they were called as moderately low birth weight infants. So there was a survey done in 2006 by Stein et al. What they did is they sent the survey to 8,000 parents of children who are born in this birth weight, and these children are now 0 to 12 years of age. And when they received the results of these surveys, they found that there's a significantly the infants who are born with this birth weight are at significantly more likely to have special healthcare needs, chronic conditions, learning disabilities, ADD or ADHD. So these babies who are born at this age are at increased risk of having problems later on. How about the short-term outcome of these late preterm infants? The study done, I think it's in 2006, 2005 by Kaiser Permanente, and they reviewed the chart of 47,000 infants who are born in their institute, and what they found is that RDS is the most common cause for the admission of these late preterm infants, and lower the gestation age you are, the more risk of RDS. which is 22% if you compare that with 0.6% when they are at term. So the term babies are those babies who are born at 8 or after 37 weeks of gestation. So definitely these babies are at increased risk of having RDS. Similarly, the risk of rehospitalization due to various reasons is increased in these babies. As you can see, 9% as compared to about 4.5% in term babies. This study is done in Korea, this is South Korea, and I think it is true even if you take these number anywhere in the world, US or any other part of the country or the world, the late preterm infants are at increased risk of all these complications. If you look here, they have increased risk of temperature instability, they are immature. They have increased risk of hypoglycemia. They are more prone to require the IV infusion therapy for various reasons. They get septic evaluation more than the term infant. Respiratory distress we already talked about, requiring nasal CPAP for respiratory distress. They have immature nervous system, so increased risk of apnea and bradycardia. Jaundice, which is requiring phototherapy, and feeding intolerance. And these babies, they do stay in the unit for a longer period of time as compared to the term infants because of these main causes: poor feeding, respiratory distress, jaundice, and temperature instability. So why these kids have poor feeding problems or the problem feeding? I mean, these babies are small, they don't have enough energy to spend, so they have less stamina. Their suck, swallow, and breathing is not coordinated because they are still immature, the brain is immature, cannot function to do all of this together. They have less effective suckling. They have less alert and awake periods. So this is also true for breastfeeding and for formula feeding. Because of all these reasons, they cannot get enough in. And for breastfeeding, if this is not happening, the mom is not producing enough breast milk. So there's an insufficient milk supply, and also insufficient milk or formula transfer, which leads to the hypoglycemia, jaundice, and poor weight gain, which can eventually lead to the readmission or rehospitalization, supplementation if the breastfeeding is not going well, and separation from the mother. This is chest X-ray which we commonly see in babies who are born in this gestation age, and here you can see there's a loss of lung volume. It's more look like a ground glass, and there's air bronchogram. And this infant also have the feeding tube. So this is a typical picture of a late preterm infant where they have this RDS, mild RDS, and inability to take PO intake, so requiring the nasogastric or orogastric feeding. Why do they have the increased risk of RDS which require the hospitalization? Because if you look at the lungs development, after 34, 36 weeks of gestation, they start to develop the alveoli. And you need the alveoli to increase the surface area for the gas exchange. The alveolar maturation also corresponds to the surfactant production, so they don't have enough surfactant. Also, there's an impaired fetal lung fluid clearance. You know, different enzymes, there's a chloride channel which is required for fetal lung fluid clearance, and those are deficient. Those hormones are deficient, which lead to the impaired fetal lung fluid clearance. So these babies get RDS, and RDS itself is responsible for about 17,000 infant admission to the neonatal ICU who are born at more than 34 weeks of gestation. This accounts for about 1/3 of all neonatal ICU admissions, and in severe cases it can lead to the severe pulmonary hypertension and hypoxic respiratory failure. Jaundice, these babies are at increased risk of hyperbilirubinemia or jaundice. Mostly it is indirect hyperbilirubinemia because of increased bilirubin production. There is a decreased clearance of the bilirubin because there is a deficient or insufficient glucuronyl phosphate enzyme which is required for the conjugation of the bilirubin. There is an immature blood-brain barrier in these babies, and that increases the risk of kernicterus. So if you look at this diagram over here, the increased bilirubin production, and because of the deficient glucuronidase transferase enzyme, this bilirubin is not conjugated and thus cannot be excreted out through the intestine and the kidneys, and it gets recirculated into the body and gives indirect hyperbilirubinemia. There is also increased risk of cold stress because they have immature skin. They have lot of increased fluid losses because of the immature skin. They don't have enough brown fat to produce the heat. Their surface area is higher as compared to their body weight. So due to that, they have increased evaporative loss from the body surface. And these babies, they require frequent interventions in the delivery room and the NICU. So if they are in the isolate, you're going to open the isolate, and that causes heat loss and increase their cold stress. Because they are small and immature, they are also at increased risk of hypoglycemia, and it occurs in about 10 to 15% of late preterm infants. They have insufficient glycogen storage, and they also are deficient in enzyme which is required for glycogenolysis and gluconeogenesis in the liver, and they also, because of poor feeding, are at increased risk of hypoglycemia. Neurodevelopmental delay, definitely they are at increased risk of that, and it can be from cerebral palsy to mild learning delays. And the reason is, if you look at this infant who are at 35 weeks, and as compared to the term baby, they're about 2/3, the brain is about 2/3 the size of the term infant. And also they have less myelination and less surface area. So if you don't have the myelination, it protects the neurons, and any insult, hypoxic insult, can cause the loss of the neurons and increase the risk of periventricular leukomalacia, and which can lead to the cerebral palsy. So how do we manage these infants? I mean, there are no clear-cut guidelines, what should we do. But in our unit, we admit the infants who are born 34 weeks, sometime who are born less than 35 weeks, or if they are less than 1900 grams. How long do we need to monitor in the unit? We don't know. Usually we monitor for 24 hours. If they are feeding well, temperature is stable, their glucose is stable, we transfer them to the newborn nursery. But again, they need to be monitored closely in the newborn nursery. About discharging these babies, the goal is for an early and safe discharge of the mother and infant. According to our unit policy, they should be more than 1800 grams. You need to assess their feeding status, temperature stability, respiratory status. They need to pass their car-seat test. For all the infants who are born less than 37 weeks, need to have a car-seat test. Their bilirubin levels should be within the normal limits, or not requiring the phototherapy. And there should be a concrete follow-up plans. For the outpatient follow-up, it should be done within 3 to 5 days of life, or within 1 or 2 days of their discharge from the unit, and which should involve weight check, assessment for jaundice, and assessment of their breastfeeding or formula feeding effectiveness. So in conclusion, these late preterm infants are vulnerable to various complications. Changing trends in the induction, C-section, multiple gestation, and preeclampsia are the main reason for their increase. And they should be managed in the least restrictive environment with high degree of suspicion and prompt intervention if needed, and they should be discharged with care. And that's it. Thank you. This is our unit, my family, and any questions? Thank you. Any questions? Another Grant.
I just have a comment. In the late preterm babies are sorry, big group, it really challenges us after discharge that we, really look at these babies closer and follow them, developmentally, feeding and all that, because they are really in a risk group. And a lot of times I think it's kind of like sometimes people look at infants or children as little adults, and if you look at the late preterm babies are as little preterm babies, but they're really not. They're unique
Yes.
groups in themselves, so they have to be handled differently.
And also we have a lot of social problems here. The mom who lives in not near the big cities, they cannot come in and bring their babies. They don't have transportation sometimes. So you want to make sure that when you send these babies out, they are hooked up with somebody who can see them within first 2 to 3 days of life. And sometimes it delays our discharge as well. And I think that's okay, because you don't want them to have problem when they go home. I think 1 or 2 days will not hurt them to stay here, but you want to make sure when they go out, they are okay. Yes.
Just a few comments in terms of late preterm. There's no question every week increase in terms of gestational age until 38, 39 weeks decreases in mortality and morbidity. So that goes without saying. In terms of delivery, why they come out at that stage, so you can simply put, is it medically indicated or not indicated? As far as the second part goes, there's a huge campaign, ACOG, Public Health, AAP, no baby should be delivered before 38 weeks. In fact, insurance companies now are not paying for those elective inductions anymore. So that's a good news. But the reality is there'll always be those borderline term or late preterm infants being delivered. But the OBs have to look at maternal and the fetal. They have two lives to play with, because mom has mortality morbidity too. So that's part of the reason they induce. We only have, thankfully, one individual to deal with. And yep, they have their acute short-term and potentially long-term problem. But you got to look at it. The OBs looking at the neonatology perspective, they say, well, 95% or more of these babies survive. Yes, there are some morbidity short-term and long-term. So they're looking at that as a gold standard to decide, well, when we're going to bring the baby out. So these are the kind of perspectives the OB have to go through. But they are both from a societal and from the insurance and from the academic societies push to keep every baby in the womb until the baby's ready to come out. But there will always be a huge group of so-called medically indicated induction, and that's arguable in terms of exactly when they get delivered.
I think you're right, and the OBs did also try to keep it as long as possible. They do understand the risk of early delivery, but there are some indications which they cannot wait for. And as I said, there is no optimal timing. It just depends on the case-by-case basis.
Even though the RDS is rare in this late preterm, but when they get RDS, it's usually severe. That's what we see. Why?
And the reason is, what happens is RDS is severe and it leads to pulmonary hypertension, because the blood vessels in the late preterm infants, they're not well developed. So they cannot relax like the babies who are born at term. So what happens, because of that increased contractility of these, or they are very reactive blood vessels. Also, if you look at the surface area of these blood vessels, the resistance of the blood vessel is dependent on the surface area. If you don't have enough blood vessels, there's a decreased surface area and increase in the resistance. So they are at increased risk of having pulmonary hypertension, and which can cause severe RDS.
Because they usually require even multiple surfactant, even they don't respond to it.
And I think that's one of the explanation which I can come up with is they are at increased risk of having pulmonary hypertension because of increased contractility of the pulmonary blood vessels and decreased surface area.
The rates in this country reflect, say, Canada, England, and other industrialized countries as preterm birth, and especially in view of the very high incidence of C-sections. How do we compare?
I think our C-section rates are very higher as compared to the Europe. I don't know about the Canada or other parts of the world, but I know for sure the European countries have less number of C-section and early induction.
We have the highest rate of C-section in the world.
Yeah, probably we are the highest one in the whole.
Does that reflect better care or more abandonment?
Probably we have resources to do the C-section, and most of our unit of labor and delivery are attached to the NICU. So that may be one of the reasons.
Yeah. I think part of the answer is we don't encourage VBACs because of the medical legal complications.
Yes.
That's why we go for C-section. That's one of the reasons.
So we don't want to take risk anyway.
First of all, I must congratulate you for choosing the topic. It's a very fun topic. Many of our residents go into practice and you get a pressure of discharging early. These are the cases that get readmitted. I have a couple of comments and a question. Comments, the most famous case, as you know, is the Kennedy. Mrs. Kennedy, first baby was stillborn, very nicely pointed out. You go too far, suddenly you have a dead baby. So the OB guy is between the rock and hard place. And as you know, Patrick, the third child of the Kennedys was 36 weeks. Had severe RDS and died. Nitin was asking why. Nitin is because of the steroid receptor. As you know, when Avery moved, they came to this country to train under the company. She moved to Harvard and was studying RDS, and she showed that it is the steroid receptors that is important in terms of surfactant synthesis. As you also asked, if you're giving surfactant, they don't improve. They don't improve because the surfactant is not going at the capillary alveolar membrane level. These you were saying, you have collapsed alveoli, it's not going there, so it's not going to improve the leaking ratio in that particular case. And certainly, hypervascular resistance is causing right to that shunt, not only at the alveolar level, but also the granular level. So that's the major cause of that. As the early, start early CPAP. Keep that in the back of your mind, and follow these kids are very, I would love to hear Diana's comments, because many times you get babies who are 2 kilos, but they're 35, 36 weeks, and they get readmitted to the ward, and I've consulted on the ward many times. The baby was lost 15% of the weight, or jaundice.
Well, I was going to say that these babies do not meet criteria for early discharge, and it's really important to remember that. And the most common thing we see with these late preterms is that they may do okay with their feedings the first 24 hours or so, but in that second 24-hour period, that's when they start exhibiting problems with feeding. That's the most common thing we see. So if you let them go home too early before that 48-hour period gets finished, then those are the babies that we see who end up being readmitted because they're stopped feeding and the mothers are trying their best at home, but even the formula-fed babies are having difficulties. And so they end up being readmitted. And those are the most common problems that we see. Obviously, the jaundice, we bring them back very early, very quickly, within a day or two, checking bilirubin levels, but the big reason for readmission we see has to do with failed feeding.
Yeah, I think the jaundice is often another problem in this babies because they use up all the enzyme, UDPG, and now there's increased RNA production, but you don't have any enzyme left for conjugation, and they get in trouble after 1 or 2 days of life.
They're not eating very well, that will dramatically increase physiological time.
You mentioned about connectors. If you remember, I started my career with bilirubin. We thought it was salt. And if you look at the reports from the 1990s, there are lots of papers and connectors research. And the reason is the American Academy of Pediatrics was promoting breastfeeding, early discharge, it was a double whammy, especially for these borderline premature babies. So cases, a whole bunch of cases of connectors reported. Correct.
Yeah.
Well, the usual doctors would fall out 2 weeks away. By that time, it's too late.
Which is too late.
It's a failure followed in the system, not necessarily a failure of the other.
It's always just losing these babies in follow-up because they said, especially here, I mean, they don't have, yeah, I mean, they don't come sometime.
Right.
Anything else?
Yeah.
Thank you.